So medical minute, just had a patient with this today. Hemorrhoids. So there are internal and external hemorrhoids. The characteristics of external hemorrhoids, they're painful, and there's usually a lump. I usually ask them, do you have a grape when you wipe? Do you feel a lump there? If they feel a lump, it's usually external. If they don't feel anything, it's just bright red bleeding, then it's internal, right? So external, painful, bright red blood, pearl rectum, and it happens anytime, spontaneously, bleeds on and off. Internal hemorrhoids, bright red blood, painless, and it happens usually with a bowel movement, then it stops. Now when it's internal, you don't really know. Sure, you can do a rectal, but I don't know if you can, but I can tell the difference between internal hemorrhoid and a polyp that's bleeding or a fissure or something like that. You still look, because if you see a fissure, then you can blame it on that. If you see external hemorrhoid, you blame it on that. And sometimes not that, it's actually a prolapsed rectum. The other day we had a guy, I have a big hemorrhoid the size of my fist. Hemorrhoids are not that big normally, right? So when I go in, it just looks like a hemorrhoid, but it's much smaller. So it was actually a prolapsed rectum and went back in. So that's the internal mucosa he was referring to. It feels like a plum, a small plum outside. And then it sucks back in and it's done. So internal versus external hemorrhoids. So the treatment for external hemorrhoids, it varies. Doctors do different things. If it's non-thrombosed and it's just bleeding, you don't do much. You give them things for pain locally. You give them to get sitz baths, and you tell them to stool softener so that the stool, when it goes on, doesn't create too much pressure. And you follow up outpatient. It's nothing for us to do. When it's thrombosed, that's when you push on it and it has a clot inside of it. And that clot hurts. So there are a couple options. One is thrombectomy. You actually pull the clot out. The problem with just doing that is that it might not work, because it works immediately, but they go home, they bleed again, and then it thromboses yet again. So the real treatment for a thrombosed hemorrhoid is hemorrhoidectomy. And it sounds like a big procedure, but it's not really. You do the same thing you were going to do before, where you numb them, and then you cut in an elliptical fashion, superficial, you get the hemorrhoid out, and then you put a stitch or two, and then you're done. That hemorrhoid will not come back because you just took it out. Now you can have others in the future, but that one's taken care of. So we can do hemorrhoidectomy in the ER. It's not any big procedure. It's actually almost the same procedure as a regular thrombectomy. And then internals, you do nothing. You can't get in there. You just send them to follow up and things like that. Internal hemorrhoids are the ones I do blood work and orthostatics and tell them, hey, everything's stable, you can go to GI. External hemorrhoids, this gentleman right today, he was fine. He didn't need any blood work or anything like that. So I went and prepped for a thrombectomy. I was ready with a blade and sutures to get it out and then suture it back together. But once I numbed him and I removed the clot, he actually already had almost like a hole in the hemorrhoid. So even if it bleeds again, it doesn't have a space to collect into. It'll just drain out. So there was no reason for me to cut into the skin or do stitches. I just removed the clot and then I was done. So we learn about hemorrhoids, internal versus external, their characteristics, thrombosed versus non-thrombosed, and then the ER treatment for it. That's it.